All right, so it's 7 o'clock. Good evening. First of all, thank you to everyone for your time and attention on this nice Wednesday night, and just really appreciate your all's tuning in for this. So tonight we're going to talk a little bit about total shoulders, talk about shoulder arthritis, the procedure of shoulder arthroplasty, who it might be appropriate for, anatomic shoulder replacement, reverse shoulder replacement, and some really exciting new developments in the field of three-dimensional planning and even moving into artificial intelligence. So yeah, we appreciate that and we'll move forward. Get going. So first, a couple just housekeeping things. Everybody in the audience is muted. We would love it if you guys would participate with some questions, thoughts, anything like that. We'll do our very best. In fact, my favorite part of these presentations is usually talking about those things at the end. The presentation is being recorded, and it will be posted on our website, and you'll get an email after this. By way of disclosures, I have in the past received some reimbursement for educational speaking on behalf of some companies. None of those things are relevant to this talk tonight. Just to introduce myself briefly, my name is Trevor Wilkes. I'm a board certified orthopedic surgeon. I've been certified for over 10 years. I'm fellowship trained in shoulder and sports surgery. I married a wonderful lady from here in Cincinnati. We have 3 kids. She's a pediatrician. We're dog people. And just for kind of my background, I've been very fortunate to have done over 800 shoulder replacements in my past. I was also very fortunate to have a lot of good mentors and partners in the past. I've published 10 peer-reviewed articles, several chapters primarily on shoulder surgery and rehabilitation, and have been fortunate to be invited to speak at a few national meetings. So let's just start by defining some terms. Let's talk about arthritis. It's something that everybody knows the word, osteoarthritis, but what really is it? To an orthopedic surgeon, osteoarthritis is inflammation and pain that our patients suffer as a result of losing cartilage in their joints. It's incredibly common in the United States. And as everybody knows, it's not a disease that you catch, right? So I can say this because I'm from Kentucky, but sometimes we talk about arthritis like you went to the doctor and you're diagnosed with it, but it's something that's been evolving with time. A lot of new fascinating research has shown us that there's a very big genetic component to osteoarthritis that has to do with your immune system and the interaction with your joint. Obviously, old injuries and lifestyle play a big role. So shoulder arthritis specifically. So I got to watch myself. I can talk for hours about the shoulder. It's an amazingly fascinating joint. Intended to give us this 360-degree movement for positioning our hand in space. But at its core, the shoulder is a ball and socket joint. We've got cartilage cushioning on the ball, cartilage cushioning on the socket. And when we lose that, that's arthritis. So you can see in the X-ray there on the image, this bone-on-bone arthritis with no cushioning. Remember that on an X-ray, you only see the bones, not the cartilage. Cartilage shows up on X-rays as a clear space in the joint. Symptoms of arthritis are typically deep aching pain, stiffness, loss of movement, and often sharp pains with quick movements or end range of movement. Another note just about shoulder pain. So for better or worse, for my business model, shoulder pain is incredibly common. So some studies suggest that after low back pain, it's one of the most common complaints of an adult in the United States. But most shoulder pain is not arthritis. The most common thing that I see in patients 50 and up in my office are rotator cuff problems. The rotator cuff are a group of 4 muscles around the shoulder that help to hold it in place. And think of them as like the fine-tuning muscles for your shoulder. Rotator cuff is something that's really prone to wear and tear, degeneration as we age. Some fascinating studies show that almost 2/3 of rotator cuff tears don't bother patients. And in my office, the vast majority can be treated very well of wear and tear rotator cuff tears without surgery. Just for reference, you can see these numbers here in your slide. that the incidence of rotator cuff tears go up linearly as we get older. And physical therapy is remarkably effective for rotator cuff tears. So what if you've been diagnosed with osteoarthritis of the shoulder? Well, conservative or non-surgical treatments can be really effective. We often begin with light activity. So that's sometimes counterintuitive to patients. They think if I don't have any cartilage, I shouldn't move the joint. But we actually really encourage light range of movement, good posture, exercises that activate the muscles around your shoulder. In fact, some interesting studies have shown that these light activities are as effective as arthritis medications often for people with shoulder arthritis. Heat and topical creams are popular. We'll often work with your family physician or primary care doctor on the safe use of arthritis medicines. Not all pain comes from the joint. Some pain comes from the soft tissues around the joint, your muscles, ligaments, tendons, and that's where massage and soft tissue treatments can be helpful. And then injections, just a quick word about injections. Injections kind of come in three flavors right now. Traditionally, we have cortisone injections, which are anti-inflammatory injections. Lubricant injections are what you all might be very familiar with from the use in the knee. Presently, that's an off-label use in the shoulder, not covered by insurance. I do think it's safe. We do it sometimes in the office, but not commonly. And then finally, there's some really interesting research out of Europe on the use of platelet-rich plasma injections for arthritis that seem to be reasonably effective. It's a very exciting treatment that can be done in the office and something we can talk about further with patients that are interested. So shoulder replacement, kind of get into the meat and potatoes of the talk. Shoulder replacement is a very good option for patients who have failed good conservative treatment. So they've tried other things. They didn't jump right to surgery. That their shoulder arthritis is a significant effect on the quality of their day-to-day life. And it's something we'll talk about in the office. And then I think it's really important to have a talk with the patients about whether they have the general health, kind of the mental place, or their head's in the right place, and they have the support around them to help them recover appropriately. I think the recovery process is just as important as the actual technical parts of the surgery. So shoulder replacement is not new. It's not common, so a lot of people haven't heard about it, but it's certainly not new. It was developed back in the 1950s by a really pioneering surgeon up at Columbia University in New York, Charlie Neer. We have studies with over 50 years of results of shoulder replacements. It is less common than hip and knee replacement. As my dad would say, God didn't make us walk on our hands. So it's just not as commonly symptomatic as hip and knee arthritis. And studies would show that there's 8 hip and knee replacements done for every 1 shoulder. But it's a very fast growing field in orthopedics. A lot of recent innovations. We're really catching up with our hip and knee partners. And we're having a good success rate. So if you look at present modern techniques, 94 to 95% success rates and patient satisfaction rates with shoulder replacement. So the concept of a shoulder replacement, as I explain it to patients in the office, is if your fundamental problem is you don't have cartilage, then we got to give you a new bearing surface. So essentially we use metal and plastic to do that. And by doing that, we eliminate the bone-on-bone arthritic pain. So here we can see in these x-rays on the image, you can see that bone-on-bone arthritis. And then when this is one of my cases, we've used a metal cap on the ball and a plastic socket to create a new bearing surface. And we'll go through this with some of the 3D planning here live in a second. So shoulder replacements come in 2 types. And these are hour-long lectures in and of themselves. But to kind of summarize it, we have anatomic, or sort of the normal traditional shoulder replacement, and reverse shoulder replacements. So to try to summarize really succinctly, the way your shoulder was designed, it has to have a functioning rotator cuff. So if you have bad arthritis and a functioning rotator cuff, you're a great candidate for an anatomic shoulder replacement. They have a very natural feel, a good range of movement, and really low complication rates. However, if you don't have a good rotator cuff, then the traditional design of a shoulder replacement is not going to work for you. That is where reverse shoulder replacements come in. So here on the opposite side of the screen, you can see the reverse shoulder replacement. This is one of my cases. So you can see the hemisphere, it's kind of the half ball that's been attached to the socket. And then there is a cup made out of plastic between the two there that mates them, so to speak. So again, that is for any reason you wouldn't have a good rotator cuff. It's been torn for a long time. You know, you lost it in an injury. It's a bad fracture, different situations. The actual procedure of shoulder replacement has become a really efficient procedure. When we make the decision to have a shoulder replacement, we start with a preoperative evaluation. You get a full set of labs. We give you special soaps to clean your shoulder with for the week before surgery, some antibiotics to put up your nose. The actual procedure is a less than 90-minute surgery. And in fact, most of ours are pretty succinctly down to about 70 minutes. We use a regional anesthesia to numb your shoulder. It's a minimally invasive procedure, and it's incredibly rare to require any kind of blood products. Last year, of my roughly 100 shoulder replacements, about 80% of them went home the same day. It can be done with good contact and monitoring really safely, and there's good research to support that. We try to have all of our patients up and walking within 3 hours of surgery. In my career of the last 10 years of doing over 800 shoulder replacements, I think that one of the most exciting developments that I've come across has been this idea of three-dimensional planning before surgery and the use of artificial intelligence. So this term here, trial without error, is something I borrowed from another surgeon up in Boston, but I think it's a great way of thinking about this. All of our patients will get a CT scan before surgery. That CT scan, the data points will go into a cloud, which then I can then, from my computer at home, actually do the surgery on this software and plan. The artificial intelligence platforms allow us to try to fit the shoulder replacement to published guidelines to optimize outcomes. And in some situations, we can actually make specific parts for the patient or specific guides. So the pictures that you see over here on the side of the screen represent a custom guide for a special socket, which is meant to bring the shoulder into optimum balance for longevity and durability. So next, I'd like to just take you through a patient of mine and how we might think about that as planning for surgery. If you will give me just a second here. Perfect. All right. So let's start here. We'll get back. So this is a patient who had osteoarthritis of the shoulder. So she has gotten her CT scan, and now we've logged into the cloud. And this is a plan that I made for her surgery. So this is an anatomic shoulder replacement, in which you can see in green here the socket, which is covering the shoulder blade. Although what's incredibly important is that we get these measurements right. So over here, I can actually turn this shoulder replacement right, left, up, and down. And you can see in real time, it calculates how well the fit of the shoulder socket is. I can take away more bone, I can take away less bone, and I can actually practice doing this surgery in my head until I get it just where I want it. This is an anatomic shoulder replacement. So here we have a plastic socket. Here, I've cut away the arthritic end of the bone, and I've put on this metal cap. And then I can actually do some analysis of how well balanced my joint is with these images. So the real value of this is basically letting me do this surgery in my head before we do it on the patient. Now, if I thought this patient perhaps didn't have a good rotator cuff, and I wanted to be ready to do a reverse replacement, so I can also plan for a reverse replacement. So in this image here, you're seeing the shoulder blade. And so this is what we call the base plate. And it's affixed to the shoulder blade with screws. And I'm going to be able to plan where I put this. And again, in real time, I can actually move this away. I can move it in. I can change my angles. And I can do all of these things until I get the shoulder replacement designed just how I want it. I've got a whole sort of data point of things I can look at. So here is the arm bone or the humerus on a reverse replacement. So we've got a stem that goes down into the bone, and we have this socket that's going to mate with the ball. And then a new development in our 3D planning is that we can now look at this in live time, and I can actually look and see how I anticipate this patient's range of movement to be. So again, we can replay this. And then what's neat is if I don't like my range of motion measurements, or I think I can do better, I can go back and try to replan it in different ways to optimize the patient's movement. There's also a whole set of parameters that I look at that have been associated in studies with the longevity of the implants. And so it gives me the ability to try to put in both high performing and long lasting. And so this is a final design, and this is actually what I did for this particular patient. Here is the socket, and then this is a new design on the humerus, where instead of putting a long stem down the humerus, we put this short spike that affixes the ball and has some advantages with regard to fractures and future surgeries. This technology is really kind of, for me, I think made me a much better surgeon by allowing me to practice these surgeries at home, to analyze my surgeries and my outcomes. As we move forward, we're using the data that we get from these sets, and we can put this into giant clouds of data and apply artificial intelligence to produce the optimum designs for people's shoulders. All right, we'll log back here. So just to kind of conclude our talk tonight and then open up for some questions. Shoulder replacement's a very effective surgeon. I'd be remiss if I didn't say I do think it's important that patients choose the right surgeon. I often encourage my patients to get second opinions, see a few different surgeons. I think there is very good published literature to suggest that surgeons who perform a higher volume of shoulder replacements have worked their system out very efficiently. Typically, these are surgeons who've embraced technology and have a nice streamlined process for their shoulder replacements. The recovery process after a shoulder replacement is kind of outlined here. Weeks 0 to 2 are really rest and relax. We encourage you to go for walks, move your elbow, your hand. We give you some postural exercises. We'll typically see our patients around 9 to 10 days after surgery, initiate physical therapy. That'll begin some stretching and the process of getting out of your sling. Depending on your sort of unique situation, you'll be getting out of your sling anywhere from weeks sort of 2 to 4. Weeks 6 to 12, you start moving the arm independently, so on your own. Week 12, you can start some light activities, practicing swimming a golf club, getting back in the swimming pool, activities like that. Eventually, by 6 months, most all controlled activities are permitted. So I have patients that lift weights, play tennis, pickleball, golf, swim. Really, as one of my mentors used to say, as long as you're in control of your shoulder, you can do it safely. It is notable that if you see patients on the street, they will often say they didn't get all their strength back till 12 months or a year. So in my own practice, I now have about 400 shoulder replacements where we've kept a database of their outcomes. We use the American Shoulder and Elbow Score. Patients complete this at their 1-year checkup. We've been really blessed, really fortunate. We have about 96% satisfaction. Certainly complications occur. I wish they didn't. We work really hard to fight those. The most common complications in my practice have been trauma. So people falling on the shoulder replacement, dislocating it. Infection is about 0.8% or just under 1 in 100. We typically follow our patients for about 2 years, and we're always happy to see you back after that if needed. So in summary, if you're a good, safe candidate, it's a very reliable, durable procedure. New advances in regional anesthesia, the use of computers, I think, are making it better and better and better. It does allow a very reasonable, light activity level. I think it's important to find a good surgeon. And I would just say for me personally, it's really become almost my favorite surgery to do. The patients who come in with their pain relief, literally had people, hug me and cry in the office, which is the most rewarding part of being a surgeon for sure. So been really meaningful for me. Now I think we will kind of open it up for some questions. See if there were any questions in the chat. We've tried to put some of our contact information for the OrthoCincy Wellington website. We have a very nice online presence, and here are the office locations that I practice at. All right. So, and just speaker, yeah, take these in sequence.
However you want.
All right. So I have, first of all, thanks again for your all's attention. Really appreciate it. Love the questions. So I have a question here. How long does it take from the first appointment to the surgery date? That's a great question. The answer I will typically give in the office is usually 3 to 4 weeks. The reason for that isn't always that we're so busy. It's that by the time that we go through getting your CT scan for computer planning, your special soaps, your blood work, we check in with your primary care physician, we get insurance approval, and we schedule the day and time that works for you and your family. It's usually 3 to 4 weeks. Another good question, is this procedure covered by insurance? And the answer is yes, absolutely. Obviously, people's insurance can vary widely as for what their individual responsibilities or coverage is, but it is a time-proven procedure and definitely covered by insurance. Here's a very good question. How long does a shoulder replacement last? To critique myself, that's probably something I should have covered better in the talk. So presently speaking, we have some very good data from databases from the Mayo Clinic, from France, from Australia, that almost 94% to 90% of shoulder replacements are still functioning very well at 1 year. Excuse me, at 10 years. So 10 years, 90 to 94% of the shoulder replacements were doing reasonably well. Now, it is true that around the 10 to 12 year mark, you start to see a deterioration in results, but we're still seeing percentages in the 80s that are making it to 13 to 15 years. Surgeons like myself are really hopeful that our computer planning and our newer implants are going to outperform that, but we need time and data to show that. I often say that orthopedic data is kind of like the light from the sun. It takes a couple of years to get to you. So hopefully that'll get better and better. What type of anesthesia? So primarily, almost exclusively right now, we are using regional anesthesia. So patients have an interscalene block, and then they will have a light general anesthesia. I actually just checked on several of my patients this morning. We did 3 shoulder replacements this morning, and they were very awake and alert within 30 minutes in the recovery room. The recovery process, as I alluded to, I always kind of joke, it depends on how you define recovery. I sound like a politician saying that. You're out of your sling typically 3 to 4 weeks. You're working with physical therapy for at least 3 months, light activities at 3 months, but certainly feeling normal, full recovery, 6 to 12 months. Let's see, how long is the hospital stay? That was a good one. So right now, a lot of shoulder replacements are going home day of surgery. We do still have a healthy population of patients who stay overnight, have therapy the next day, but it's rare to be in the hospital more than 1 to 2 nights these days. Here's 2 questions about PRP. So is PRP covered by insurance? Great questions. I was actually just at a seminar at the University of Kentucky in Lexington on shoulders. We were talking about this. Presently, PRP is largely not covered by insurance. Interestingly, the insurance industry suggests that once you have 6 placebo randomized controlled trials, that they will cover something. And right now, if you count the trials out of Europe, there's 8. So we're very hopeful that it'll be covered really soon, but presently not. So it's an out-of-pocket cost. We buy the materials from private industry, and so we have to recoup some of those costs. So right now it's about $600 for an in-office PRP injection. And then here's a question about what are some of the typical treatment options that are considered before shoulder replacement. I would just say I really try hard to work with my patients to be sure that all of options have been tried first. So safe use of medicines, light therapy or activities, lifestyle changes, injections, etc. And then here's a follow-up question about PRP. Does a patient typically need several PRP injections? That is a controversial question. Right now, it depends on the study that you read for the person that asked that question. There are some studies that are done with just one injection. There are some studies that are done with several injections spaced apart. I'm gonna kind of answer that one as it's to be determined. In my practice, I will typically provide one PRP injection, and then we'll see the patient back in a few weeks and kind of see how they're responding and talk about those issues. So that's a great question. All right, well, I think we've covered most of the questions from the audience. And again, I'll just express my appreciation for people's time and attention and willingness to consider more information about shoulder replacements. And please reach out to our practice at OrthoCincy Wellington further if needed. So thanks very much.